Welcome to the Health Commission Community and Public Health Committee meeting of Tuesday, June 18th, 2024.
I'll call the roll. I'll start with you, Commissioner Gerardo,
Present?
Commissioner Christian,
Present.
and Commissioner Chung.
Present.
I will also read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the agenda are the minutes of the May 21st, 2024 meeting.
I move to adopt the minutes.
I second.
Any public comment? No public comment on this, commissioners? All those in favor?
Aye.
Aye.
All right, thank you. The minutes are approved. We can move on to item 3, Public Health Laboratory Emergency Response Readiness. Let me pull up the presentation. All right.
Okay, thanks, Mark. Thank you. Good afternoon, commissioners. I'm glad to be back again. Last year I was here. I gave you a kind of overall overview of our public health lab and what we do there. This time I've come back with just one of the 11 functions, main functions, which is readiness for emergency testing. And that's what I'll be conversing with you today to update you on what at national level until we reach on our local level here. So next slide, please. So just the outline, things that I'm going to go over is, of course, our OCCHAT, just to orient ourselves on where PHL is. And then I will also orient you on the national level, how we are organized to be able to respond to emergencies. And the next thing is to look at how ready are we as a public health lab here for DPH. And then finally, we'll look at the continuity of operations in case we go down flooding or earthquake. And also just share with you our new lab that's coming up that will have our BSL-3. I'll talk about it a little bit. We talked about it last time. And so I'll be able to end there. Next slide, please. Okay. Just for orientation purposes, you see that we are in DPH, we are under population health, under Dr. Susan Philp, and then we are one of the branches of PhD. Next, please. Then in PhD, we are under the public health services as one of the branches. Thank you. The next slide. So as I said last time, I talked about all these 11 core functions of public health labs, which was set up by APHL, the Association of Public Health Labs, and CDC. And this normally, the public health labs are normally governmental laboratories that work together to perform those 11 functions. And one of the other things is that we collaborate with also federal organizations like the CDC, the FDA, the EPA, the Homeland Security, Department of Defense, but we also work together with other laboratories like the private labs, the hospital labs, and also university labs and other respondents, first respondents, that we work with those. So next slide, please. So before, as we move to that slide, I marked out the emergency response. That's the one that we are going to focus on today, but I will go through to be able to then bring you up to date where we are with ourselves here. So as a public health laboratory, we have networks that helps us network together. All of San Francisco is networked through us as a lab. We have divided them into 3. We have the local, who are mostly the units that they provide us that bring us specimens for testing. And also we send, of course, results back to them. Then we also have the state where we have a CDPH lab, which is our reference lab. Then we have CAFOL, which is California Association of Public Health Lab Directors. All of us, the local labs, we belong to that association. And then we have the LRNP, which is Laboratory Response Network P, that deals with infectious organisms. We have also the federal, where we work together with the CDC, the FDA, FPHL, and NIH at the same time. So that's important, so that we can be able then to be able to help complete our mission. Otherwise, we cannot be linked to these organizations. That's how we complete our mission to the city. Okay. Next slide, please. And just here is to orient you, to show you that the country has a national laboratory response network. So it's not just like we are standing on our own. The country as a whole has a national laboratory response network. If there's an emergency like what we had, COVID, then there is a response, there's an organization. And as you see, it's in 3 levels, where we start off with the Sentinel labs, which are the lowest, and then the national lab, which is a CDC lab, that's the national lab. So at the moment, we are at the Sentinel lab level, because we don't have that BSL-3 that I'll talk about. But when we get there, then we'll move to the next level, where will be a reference lab. So if you look on the side, what it means, if you're a Sentinel lab, you cannot completely ID any organism and say, yeah, it's this. You have to send it to the next level, which is the reference labs. And then the reference labs, if they cannot be able to do it, then they send them to the national level. So you kind of go from down step to the top, which as you can see on the right-hand side, defines for you each section what you can be able to do when you are characterizing an organism. And you can see that the higher you go, the better that organism is characterized. Okay. Then next, we are going to look at the California one. Also, we have a state one. Apart from national, we have a state one. And in California, we divide it into what we call catchment areas. So these catchment areas, because we don't have all reference labs, what happens is that all the ones in bold are the reference labs. That means they are the second level. If you remember what I've just talked about, the national level, they can be able to ID those organisms much better. So each one of them has an catchment area. If it doesn't have that reference lab, those other labs nearby can send the organisms there. For example, for us here, we are the smallest county. If you see that arrow, CDPH, we are the smallest county, and we are served by CDPH. So anything that comes in, we can't identify, we send it to our state lab. So that's where we are at the moment. And then we also have other labs like Santa Clara, and then we also have Sonoma County. If the state cannot be able to do it, like when we were struggling with monkeypox testing, they told us to send to either Sonoma or send to Santa Clara, which of course they could not be able to manage it. We had to end up developing our own assay to help us with the volume. Okay, next. Okay, and I just wanted, before I get down into the details, just to show you, I'm sure you have heard of this looming outbreak of the H5N1, which is a highly pathogenic avian influenza, which you have heard of. We have heard of the live chickens in San Francisco. And that's what we are looking at the moment. And what we have is that the lab has this already going. And we have already been testing samples from October of last year to just try and see whether there's anything. So far, we have tested samples up to June this year, and we haven't seen anything unique yet. So that'll be coming. But just to kind of alert you as I move along, to update you on this, that our eyes are on that, and that's part of our work. Already our eyes are on that. We have an assay going already, so there should be no problem. Okay, next, please. So, and I just wanted to transition now into what resources do we have? Are we ready? If anything comes up, just like were we ready when COVID came up? Were we ready when monkeypox came up? And are we ready now with the H5N1? That's why I wanted to transition with this slide, so that I get you ready. And for us to be ready, we need some key pieces in place. That's very important. You have to be able to have these key pieces for you to be able to be functional. And one of the key pieces, I talked last time about our training, our interesting training that we do to fill our public health micros that you cannot get easily. We have that program that we train our technicians to become public health microbiologists who are very well trained to be able to handle some of these organisms when they come, because they'll be technically trained and licensed to be able to do that. And that's why I wanted to show this. And I'm circling that 2463. Those are the microbiologists that are trained and can be able to go into emergency quickly to be able to protect us or the community to be able to test. That's why I highlighted that. And as you look at it, there's no vacancy, which is, it's not like it's something that we are putting there for the sake of it. There are labs around us that have advertised for over 2 years, they can't get even a micro. But look at us with our training, because we train every year at least 1 or 2 people. Like now we have 1 training which is going to be finishing next month. And so if we lose any of the micros, we already have somebody to be able to replace. So that training has really helped us from other labs who are struggling, who have been struggling a lot, who could not get these public health micros because they go to private sector. Private sector pays them more than we do. So we have to have a continuous supply line. That's one of the keys. That's why I wanted to highlight that, because workforce availability and retention is the biggest problem in public health. And we are working on it, not only the lab, but also other areas of public health. Another resource that you have to have, of course, apart from the staffing, you have to have equipment. And I talked about diverse equipment last time, and this time I want to place it a little bit differently. The way we have our diverse equipment is that this equipment is important, because what will happen is that we use it in so many ways. With this equipment, for example, with COVID, we ended up, some companies could not have reagents. So if you had only one type of company and equipment that you are using, then you are stuck. They didn't have reagents, you could not be able to test. We were very lucky that we had Abbott Alinity, which was a company that never lacked the reagents. The Hologic lacked reagents, but we have that, but we never had to use that because Abbott Alinity was going with all the reagents that we need. So we really did well. We tested as much as we could be able to test. That's why diversity is good, but also redundancy. Let us say we need to do other testing. We can go to any of these machines. Most of them can test the same tests that we want to do. At the same time, let us say we want to do a lot of specimens at the same time, then we can run all of them at a go that do the same test. So that's the beauty of having this many diverse equipment to be able to be used, so you don't lack. We also have, if you look through, you find that the CLIA labs, that's a sequencing system that we are now using to sequence gonorrhea, and we'll be using to sequence TB. We'll be using it to sequence COVID. And then in the long run, hopefully, we'll be able to also use it to do wastewater sequencing. At the moment, we don't, but we'll be able to do that in the long run, especially when we settle down in our new lab. So that will be able to assist us. So we have at least an equipment ready to go when we get there. Yes. So I just wanted kind of to share with you these 3. I'm sure you are remembering COVID and the Mpox. They are still going. They are not gone away. We are getting positive samples. Even today, we already reported positive samples today as I stand here. So these are still going, but we keep testing them in lower numbers. But if they go up, we are ready to go. That's why we have all those equipment. We are ready to go up. Right now, we have, like COVID, we are using a machine that can test a few samples quickly, so we don't have to go through a longer process. But when it becomes like we need more numbers, then we have all those diverse equipment to be able to be used. So we are really proud of having all these together. Of course, we give the ELC grants were really the part that helped us play that role of bringing in all this equipment. So really helping us. So we are always ready. H5N1, as I've said, we are testing them right now. We started in October. We have been working with our communicable disease unit to make sure that we started in October to see whether there was anything in October before this live chicken that were got in San Francisco. So we have tested all the way now to June. We haven't seen anything unique other than the normal H3 or the normal H1N1 that we had in 2009 and so on. So we haven't really got up anything unique. If we get anything unique, of course, we send it to the state lab to be able to confirm. So that's why we keep testing. We cannot stop. We have to keep this, but we are ready, as I've shown you, that we have the resources to be able to ramp up if we need to. And one of the key things we have done, and I talked about monkeypox test last time I was here, and we had just developed it when we could not be able to have anybody test our specimens because we had a lot of specimens, and most of the laboratory response network labs that were reference labs could only do 20 a day. And we were getting 80 a day for San Francisco. Then we had to see what can we do. So we developed our own test, and we call it a 4-plex because within the same one single well, you can be able to get all the types, including clade 1, which is now the one that is coming up and is an outbreak in the DRC, Congo, in Africa, which is more harmful than the clade 2 that we were doing before, that we had here before. The clade 1 can actually kill you. It's not like the clade 2 that just maims you and will not be able to kill you. So we developed this assay, and APHL and CDC have taken it up, and 18 labs have actually taken it up. We have the advantage of this assay is that time to get it ready to test a patient, we shortened that time to about 2 weeks. Normal time is 6 months for them to be able to get that assay ready. But for our assay here, after working together with the FDA, we work together with the advantage because I'm also on the board of APHL as the Secretary Treasurer. So with that advantage, we work with the FDA directly to be able to help guide us along. And we could do it in 2 weeks. So we are helping other labs do it at the same time. So it's 2 weeks instead of 6 months, they can get an assay ready to run. So that's one of the things, but also you can run over 200 samples a day. You don't have to run only 20 like what the CDC had developed for us before that. So that's the beauty of this assay, and that's why I put the map up. The map is up, The map is up, and those are those are state as well as local labs that have that assay. That is our assay that we are helping them to develop quickly to get it ready in case that outbreak of clade 1 happens, because CDC has asked us also to be able to help. We have tested a few samples from Iowa State Lab to be able to help them if there's clade 1. So that has been really something of our centerpiece, and the same has been accepted in the SDD conference in September for us to present orally as a paper to that community in Atlanta in September. Okay, next please. So electronic data exchange, this is one of the most important part when we try to communicate the results or communicate anything. And that's why you see that all this is secure, encrypted result sending. So it's not like you're just sending like on the internet. This is encrypted data that goes securely to all this. You will see that some of them are 2-arrow way, some of them going and back, and some of them are just one way. Like see this, we only send on that system of theirs, Philip, one way. They didn't have this for COVID, so we had to fax everything to them. But now with that program there, we can send that directly to them without having to make faxes, because that really takes a lot of time to be able to do that. Then you can see that the CAR-ready, the California has reportable diseases, and for us to be able to send those whenever we have a reportable test comes up in our testing, or during our testing, it can go directly to what their system called CAR-ready, which is also another secure system. HL7 messaging is a secure language also. So that way, that's encrypted because we send PHI data with that. So that has to be encrypted because the patient samples. The same way with the primary, these are different programs because each one of them have a different capability and they have a different program, and that connects onto our program, which we have called Apollo. That's the one that connects all these other data, and it's very secure connection. And most of this depends on when we send it is when there is a need. For example, for City Clinic with Epic, they send us samples for patients, they order through Epic, then we send back results through Epic. So the moment it's done, you send that back right away. You don't have to wait and fax or do anything else. So it's really quick in this era of electronic exchange. You don't have to be able to fax. Actually, the old faxing is gone. We are now just, things are going electronically. Although we also have a system that our system can be able to fax automatically without also going into to be able to fax manually as we used to do. So really, this is what is really important. That's why you see some of them have 2-way because we can only do like CDC is only 1 way when we report something that they need us to report, like COVID. But the others are, we exchange at San Francisco AIDS Foundation, ECW, they order samples to be tested, then we send that results back through the same ECW. So because that's the program they use to analyze their data and follow up the patients and do whatnot, we cannot send them through another system. That's a system that is used for them for their purpose. So they are only sent out when that purpose is needed. So we don't just send all the time. So you might wonder, we are sending them all the time. No, each one has its own purpose. When that time comes, then we send it that time. So that's how it happens, but it's all encrypted, secure data. Okay. Yes, yeah. So the other part I wanted to just talk about is what about when we go down? What about if there's an earthquake and the building is not safe? What about flooding? What about fire? What do we do next? Always we have to have that continuity or continuation of operations, which is the COOP. And that's one of the key things that we have to be able to reroute our specimens. Like you saw that electronic rerouting to the local labs, we can be able to reroute them electronically to the local labs. All the public health labs in the California, we are connected. We are 28. So we are connected so we can route them, especially to nearer labs like Almeida, also San Mateo, and so on. So there are areas we can route those through primary because we are all connected to that. So you don't have to say a call and say, make a call. You just route it by ordering it through primary, and then you send the specimen, and then you get the results back. So it's really something that we really like because it's very easy. We used to do a lot of faxing. We had a lot of papers in the office that it was very confusing, but now we have almost nothing there. So we are going completely, anything we had as paper, we are scanning that also into the system. So you don't have to keep the paper alive, but you can be able to get that if you want it by going in the system and printing it out. If the inspector, like we just completed our clear inspection, and I will talk about that a little bit at the end. Okay, next, please. And then the future of our public health lab, I talked about this last time, and we are very excited right now. And just on the side, we have simulated the lab on the right-hand side, and on the left, of course, that's how it will look when it's completed. And I talked about biosafety levels last time. The higher you go on the biosafety level, the more risky whatever you work in there it will be. So you have to be able to know that for example, BSL-1, which is biosafety level 1, that one, the sample is not known to cause any human disease. But as you go to 4, that's the one that actually can be able to, it's very dangerous, it's high risk, can be able to kill you. So that's why we call it BSL-3 will really help us because we can be able to do all those indigenous or exotic agents that could still also be able to harm you seriously. So that would be a very safe side for us to be able to do some of this testing. And if we want to move to a reference level lab also, we can apply to do that. That's why it's really, it's a nice thing to have a BSL-3. It's the safest San Francisco will have in years. So that would be really a plus to us. In case something comes up and we can't be helped like monkeypox, we can be able to jump in and do our own thing other than waiting for somebody to help us. Okay, next please. And this is, I just wanted to share with you that construction site is taking shape now. When you look at it, it's now taking shape. So we are getting there, and we are hoping by July of 2025, we start moving in, and hopefully by November of 2025, we'll be done. So we are really looking forward to it. But what is going in is not just construction. We have a lot of meetings going on right now. Public Health Lab is being supported by ZACBAC San Francisco team under Dr. Susan Erich, and then operations team here with Daisy is supporting us. So we have a lot of meetings to look at how do we move in that day, what is the safety regulations that we need now to change and follow at the hospital, what are the material support that we get at the hospital, and so on. So we are having these meetings to be able to make sure when the time comes, we know that we have IT there now. We are not going to use our IT here. So we are going on with these meetings. We are meeting all the time. We have smaller meetings that are meeting regulations, anything else. We are meeting to make sure that we are ready when the time comes. It is very smooth. So it's a lot of work going into the back, being supported by ZACBAC and also being supported by our PhD, our own PhD here. So we are really glad that that is there, that support is there. So we cannot do it ourselves by just the public health lab. We'll be running because what we will do is we'll open 2 labs. We'll have 2 labs. We'll have this one running here. We'll have the new one running, so I'll have to apply for 2 licenses, and then we'll be running both sides. So that's why we need help, so that we have a coordinator who will coordinate the moving. As we are doing the moving, we are testing both sides. Because moving a lab that is certified by CLIA you have to do it very systematically, otherwise you go out of regulations and you can be closed, which is not good. So we are working on that. We just got our CLIA done. So we got our CLIA now for the next 2 years. And then we did also, apart from this main lab, we did also the city clinic also passed, the jail also passed. So we got that just done by last week. So we are really glad that now we are okay for the next 2 years. because that's now done. I'm sure you realize how important it is when these certification organizations come in. If you play and then anything closes down, you have a problem with them. So we have been very good at this, and so far we have been very good. And that's done now for the next 2 years. And then when we open the new lab, then that's the time again they will come after we start testing. They don't come before you start testing, they come after we start testing. So that's one of the other things that we'll wait for. But we are glad that now we can focus on the moving and just testing as we're going on. Okay, and the final slide is just if there are any questions, I'm more than glad to answer them. Thank you.
And there's no public comment.
Great presentation. Thank you. Very well organized and a lot of information. I'll just start at one of the last things that you said about the 3 or 4 different labs and different places. The lab in the jail, can you just describe briefly what happens there?
The lab in the jail, the reason why we set up this, I remember when we were talking to Dr. Susan Philip, we said, it's better to test closer to the patient and the clinician than when they come here, because what happened, we used to miss a lot of patients. By the time they come here, we are taking about 2 days or 3 days to return the results. That person goes through jail because they just come in and they might be already out and gone or moved to another place. So we used to miss a lot because those are high risk cases. So you always used to get a lot of positives, and we used to miss like 30% of the positives. That's the reason we put a system there. The tests we do there are like 1 hour and 30 minutes max. It's done. So if a person is positive, they'll be treated and they're out of there, so we don't miss them. And the same thing with City Clinic, which does homeless and tourists on the street, because like homeless, you're not going to find them next time. So with that, as they're being examined on other things, the test is already done. If they are positive, then they can be treated. That's why those 2 labs were set up strategically to be able to capture the patient and the clinician together, so they can be taken care of instead of coming here and then going back when they're already gone.
Is that staffed on a daily basis at the lab?
Yes, staffed. It has actually a microbiologist there. Both of them have a microbiologist there.
It's fantastic. And I know that there have
Those
been,
are extra, really extra labs. They're independent. They have their own clear licenses.
and that's so important just in terms of getting people not only understanding whether they're ill when they come in, but when they are ready to go to leave custody to a treatment facility, there are tests that need to be had. And in the past, that could delay someone's placement, but it sounds like that time frame has been shortened.
Yeah, we have shortened that time, and intentionally, we built this from what they used to call the London street testing. Actually, that's the model we took to be able to do this. And actually, New York took our model here and even built a bigger one in New York to be able to do theirs. So it was really something very, very enticing, because we don't miss these high risk populations that go through.
Well, the foresight that you've shown and that your lab and your colleagues have shown is just amazing and wonderful. So
Thank you.
appreciate that.
Thank you very much.
Thank you. Thank you for your excellent presentation. I have a couple of questions. On the diverse equipment, all of the equipment, and
Yeah.
you had just mentioned it. Is this used now for wastewater testing?
Not yet.
Okay.
We don't use that now, but in the future, we are hoping when we move, the sequencer will be the sequencing machine, Clear Labs, if you look on there, that's the one that will be
okay.
potentially used for wastewater testing.
And I know there is wastewater testing somewhere. Where is the wastewater testing?
Tested at Wastewater Scan, it's a private lab, and also tested at CDPH. That's the state lab. So we have those 2 places.
Those 2 places are with the information.
used, yes.
Okay. My other is on the electronic data exchange, which is wonderful. How and when does the exchange decide to send the data?
That's
What
why,
are the benchmarks,
yeah, that's why I was talking about the purpose.
Yes,
The purpose. Let us say it's a patient sample that was sent to us,
it's,
but then when it's done, it's just sent back to that particular provider. If it's like already where we report Title 17s, as soon as it's positive, we have set up the system knows that if this like gonorrhea is positive, it will be sent to the state to report to the state. So it's all set up purposely when there is a reason to send something, then our laboratory information system will automatically actually send that securely to each one of those partners.
So you have then a protocol or certain benchmarks or certain things
Yeah.
when they're tested like gonorrhea or whatever,
Yeah.
those, you have a list of what those tests are that are then disseminated through the exchange.
Yeah,
Am
through
I,
the
am I
exchange.
right? Or,
Yeah, yeah. What happens is that Apollo is set in a way, that's our LIMS system. It's said that it knows if it's gonorrhea, if it's chlamydia, if it's TB, it needs to send it to the state. Those are reported, some of the reportables, malaria and others that are unique, COVID and so on. Those, the system is set up with an algorithm that it knows that it has to send this automatically. We don't have to go in and say, oh, now.
that's what I
this is
mean,
positive.
yes.
No, that was the tedious part. That's why I said it was the tedious part before the electronic exchange. But now with the electronic exchange system, Apollo is set up in a way that it's just written a language. If you see this and it's gonorrhea or chlamydia or TB, you send it to Car Ready. If it's for CDC, again, it's the same way. If it's a CDC requirement, then it will be set to go to the requirement. So that's programmed. It's not like you will go in and pick one by one, because we do close to about 170,000 samples of chlamydia, gonorrhea alone. Forget about the other tests like HIV and hepatitis C that are required to be reported.
I see. Okay.
I
So
hope that
you,
answers that.
so you
question.
push the button.
Yeah, actually, you don't, it's automatically goes. The moment you send, you result the result to whoever they send it to you, it also does the sending to where it needs to go.
Okay.
If it's for Car Ready, it goes to Car Ready and goes.
Okay, so it's all part
Yeah,
of it.
it's all automated in the
Okay,
system.
and I have, do you have any questions, Commissioner? Okay, I have one other question,
Yeah.
or no, just maybe an update.
Yeah.
In your last, or in the last presentation on the core functions,
Yeah.
one, and I don't know if you've got this information, and I'm kind of got you off guard here, but one of the core functions that we discussed at length was food safety. And that at that time, when we were talking about vendors and the carts and whatever, there was, some discussion or some presentation that, the food safety officers were often, attacked or whatever. And I think it was in the process of possibly hiring more food safety officers or whatever, or people, I don't know. But do you have any more information on, the progress in the food safety with the vendors, the food carts, not
No,
necessarily the
not those
food
ones.
trucks, but the food carts that are on the street that I know that there was some frustration.
Yeah, I think the environmental health services, I think that's the one that deals with that. We don't normally deal with that. Normally what we deal with is, let us say, they get a restaurant where workers have like maybe infection with Salmonella or Shigella and they want clearance program. Then they send those to us.
Okay.
Then we'll say, okay, this person is cleared, then they go back. But we don't deal with food safety. It mostly should be environmental health services.
Okay, it is. So you deal with, if they send samples to you to see whether or not,
They are cleared.
the confiscated hot dogs are contaminated or they're whatever.
Yeah, normally it's the workers of the restaurants.
Yes.
If they get infected and they have to go back to work, we have to show that they are no longer infected. Then they go back. That's part of our job. We don't never go to the field outside to do anything.
Okay, it's all brought to you
Yeah.
for testing, is
Testing,
my
that's what
understanding.
we do most.
So
yeah.
the food safety personnel are different.
Yeah, they're
Yours are the lab personnel.
Yes.
Okay,
we always
that's
just
what I
wait
was-
to be sent samples and then we can test those for
Okay,
clearances. Yeah.
that's what, when I was looking at the core functions, I wasn't exactly sure which was which.
Mostly
et
when you
cetera.
go to they call it that way because most of the state labs actually do more than we do other than just clearance. The state labs do more than that. So the core functions are for public health labs. Some of them we do just part of that. But the major part of food testing, when you go to the state lab, they do all sorts of food testing.
Oh, they do.
Yeah. They do all sorts of food testing. Us, we do only clearance, but them, they do all sorts of food testing.
Okay.
Yeah.
Thank you.
Thank you.
That's what I was.
Well, thank you for the presentation. So I have, I just want to get some clarifications on the last questions that Commissioner Geraldo asked. So basically, like the only thing that you test is blood samples coming from clinics or whichever lab that's been drawing those samples. Is that correct?
Yeah, normally we do not only blood samples, we do swabs, we do stool, we do a few different sample types.
Okay,
We
yeah.
cover all those because like our STI is some of them are mostly swabs, like chlamydia, gonorrhea are mostly swabs. But when you are dealing with HIV, hepatitis C and so on, those are blood samples. So it depends on what sample. When you are doing with a TB for quantiferon, you'll be able to get blood sample for you to be able to test that. So we get different types of sources. So it's not only blood, we get different types of sources that we are able to test. But all those, most of them are FDA approved tests that we do on those machines that I shared with you. So normally they have to have those specific sources. You can't just test any source randomly. There have to be sources that are FDA approved sources for you to be able to test on those machines.
Okay. Thank you for that. The only questions I have is in terms of, because there are private labs and, there's public labs and, and because like everyone's required to do reporting
Yes.
upward. So how do we actually communicate with other labs, like within their same jurisdiction? So to make sure that we are not double reporting something?
No, actually, the thing is everybody is responsible for what they are testing. Each lab is responsible for what they are testing. Because we are testing one patient, one side, even if it was the same patient, then it would be, you just report it because that's your jurisdiction. You have to make sure whatever you have tested, because you don't know whether somebody else has tested that patient, because you don't know that information.
Yeah,
So
so
we never-
that's my curiosity. That's exactly my curiosity. So if somebody's actually a public health patient, like who comes in and get regular blood draw, but they present themselves in the emergency room of a private hospital and they got a blood draw there.
Yeah.
So they will have to go to two different labs, but the reporting, how do we make sure that, like we have ways to
Streamline. Yeah.
to make sure that, like we are not looking at the same person. Yeah.
Yeah, we don't have control over that, unfortunately, because ours is just, you have brought us a test, we just test it and report it back. We have no idea who is testing where else again. But sometimes what happens is, if the doctor looks, let us say they go to Zuckerberg, San Francisco, and maybe they had gone somewhere else, but we use the same EPIC system, that clinician will be able to see that they were tested somewhere else, and sometimes they'll just refer with that result they have, if it's the same system. But if it's not the same system, they will never know that they went to another place. It has to be like EPIC now. If they go to any other clinic within DPH, they'll be able to pull up that information.
And Commissioner, if I could just add, it would be also other health systems in the city, because most of them are on Epic.
Oh, okay.
So, if I have a patient at Ward 86, whether that got tested at City Clinic now, or if they got tested at one of our primary, at the central lab,
Yeah.
or if they got tested at UCSF, I could
Yeah.
see the test result.
Okay,
Yeah.
yeah, so that's actually, like the biggest question I have, because like for the longest time before Epic, I was
yeah.
wondering how.
Oh, yeah, you couldn't even see tests within our own system.
Yeah.
Yeah, okay,
Yeah, but now you can see if it's the same system, they'll be able to be picked up in EPIC because we are all connected to EPIC. Our laboratory information system is connected to EPIC. When they order from EPIC, but it comes into our laboratory information system. So if the clinician went back, they'll be able to pick up that information.
Thank you, that makes a lot of sense now, and also it highlights the importance of all these new technology.
Yeah, yeah.
But wouldn't you then need to go on Care Everywhere? Let's say you had LabCorp at Sutter or whatever, and yesterday.
Yeah.
And then you came to Southeast, clinic and, and that physician was requesting requesting a test, but they had already had it. That physician, would need to go on Care Everywhere on Epic then to see if the information was there from another institution or another lab?
No, they won't be able to, unless they are on our Epic system that is
Yeah.
part of DPH, they will not be able to see that. So like LabCorp or Quest, they're outside of our system. So you won't be able to see that unless you are within what our Epic system has captured within DPH, or the clinics of DPH, City Clinic, maybe other clinics that are around us, or Zachbach, the Ward 86 or something else, wherever they went. If it's within DPH, then it's on the same Epic. When they log in, because the patient has an MRN number, when they put in that MRN number, it will pull up all the tests that the patient has had. Whether they had any other clinic, if they were City Clinic, they went Ward 86, for example, then they can capture that. But
So-
if it's outside our system, we won't.
Yeah, Dr. Missoni, I'm just trying to distinguish also between the getting it tested, like a private lab like Quest versus getting tested at another healthcare system that's linked with Epic, like UCSF, right? So if there's a patient who got tested at UCSF, that work would show up in Epic under Care Everywhere.
It has to be the
It would be linked to the patient, yeah.
clean lab that we have at Zuckerberg. That's the UCSF clean lab. I don't think out of UCSF itself, I don't think we are on the same.
Oh, I can see it through Care Everywhere.
Oh, you can.
So there is a care, but I don't, and we can get back to the commission. What I don't know is how Quest or other private
Yeah.
labs would get that if it were only in that and not in the healthcare system.
Yeah,
So we can
'cause
find
I
out.
also would assume that, like those tests would be requested by their providers. So, like even though the lab itself might not have those, like the information,
That's what I'm saying. If it were through
if it's sent back to the
UCSF or
provider.
Kaiser system, it should get through. And we'll come back to you with the issue. And Dr. Bassett, maybe you can talk to the commissioners a little bit about Beaker, because that's part of the EPIC work that you're leading with Eric Raffin, because I think that's also connected to this. What I think the question is, how do you simplify the electronic health record to make sure everybody's getting the lab results as quickly and as aligned as possible, right? So maybe you can just talk about Beaker really
Yeah.
briefly.
We are presently getting ready to bring on board Beaker, which is part of EPIC. And this Beaker is going to capture UCSF lab. It's going to capture the pathology lab, and it's going to capture PHL lab here. So we'll be all on the same LIMS system. So if they go to UCSF, then they should be able to come into the same EPIC system. So we are all going to be on the same laboratory information system. So that's coming up. It's going to be launched soon. And then we'll be able, by next year, I think around July, we'll be all on the same system after we are moved. So that means that when somebody orders from the LIMS system, which is Beaker actually, which is part of EPIC, then you can be able to see that information from UCSF as well as DPH clinics. So I don't know whether that's enough.
So, but any other institution, that's what I'm trying to be, is they would need to be part of Care Everywhere, because not all of them are.
Yeah.
In order then, so if it was at Mission Neighborhood Health Center and the lab work was done, they're not in Care Everywhere. So it would not be accessed. So it would need to be the institutions that would be part of Care Everywhere, and then the physician ordering it would need to be enough to be able to do care, make sure that they've accessed Care Everywhere to see, correct?
I believe that's correct, and we can clarify with
Okay.
our medical records folks.
Yeah, we're just looking for the overall
Overall, yeah.
coordination and who talks to who through.
Yeah,
Mama
but the
Epic.
three labs will be coming together with Beaker. So we'll all, whether you go to UCSF lab or you come to PHL or you go to pathology, they will all be on the same system, which is actually Beaker, which is EPIC, but it's a module out of EPIC called Beaker that the lab will use to transfer the information.
So instead of having to manually input the results
Yeah.
to get into the system, Beaker just picks it up.
Yeah.
Okay, well, thank you very much. We're just also looking at, from our questions, make sure the left hand and the right hand are communicating as much as humanly possible.
Yeah.
So, but thank you very much.
Thank you.
And we look forward to your move into the
Yeah, I will share with you our BSL-3, which is, as I said, the safest place you can work with all these other organisms that are more dangerous, they're high risk, and that's the safest place to work. It's all it's set in a way that all the air exchange is on its own. It doesn't mix up with any hospital air, and there are filters that they inspect every year and change them so that they are very efficient. If there's any air exchange problem in the BSL-3, the alarms, they shut down the system so you don't have to get infected. So it'll be something really, really interesting for us to have, and also something that is another step up for the public health lab and DPH.
Yeah, once you move, we'll be interested in your coming back and telling us what more you can do and
Yeah.
how your testing has been able to be expanded,
Yeah, we have a lot to be able to add in.
which is great. Great.
Thank
Thank
you.
you so much.
Thank you.
Commissioner, if I can just add, because Dr. Masindi is, brought a lot of detail, but I just want to acknowledge his leadership and the work that he's done with the team. He's done an amazing job of mentoring people, of promoting the importance of diagnostics, and really on the fourth floor, running a state-of-the-art laboratory in a building that is not state-of-the-art. So just to be clear, there's this dissonance, and it's kind of amazing visual where you have these incredibly up-to-date machines and diagnostic mechanics going on that Dr. Masinde brings in, things that, he's an early adopter of the latest technology, and you have that in a building that, doesn't have internal environment control. So it's pretty amazing what he and his team are able to do under circumstances that, will improve once the move happens. And I also just want to thank him and his team for their work in diagnostics during COVID. I mean, they were incredible getting things out far ahead of the rest of the country, really the leader in that during MPOX, transforming the way we test for STDs. So just to acknowledge that, I like to talk about the amazing leadership in the department. And this is really a place where this direct service to the patients is incredibly improved and modernized, and up to date, and also a place that is the model for so many laboratories across the country and the state.
Thank you, Dr. Colfax. And just to acknowledge our team, we have part of our lab team here because some have to keep testing in the lab, but they all came along to support the lab and what we do. So we really are grateful for the team, and very incredible team. And as you can see, we have really done as much as Dr. Colfax is saying. We are a little bit more and beyond what we can do. Yeah.
Commissioners, can we give the staff a little round of applause? Thank you so much for your work. And if we may move on, because we need to get ready for our next meeting. Thank you so much.
Thank you very much. Yeah.
Item 4 is emerging issues. Hearing none. Item 5 is public comment. As we noted, there's no public comment, so we can go to consideration for adjournment.
Move to adjourn?
Second.
All those in favor?
Aye.
Thank you so much. Give me 30 seconds to close out the meeting.